This is an introduction to manual osteoperforation and high-frequency vibration. My name is Ben Miraglia. I'll be conducting the next hour. Thank you for joining us. Basically, the disclosure, I'm not employed by a dental company. I do not own any stock or securities or interest in any company, nor does my family. So we have covered these details, so we're good. I've consulted for the following companies: Propel Orthodontics, Align Technology, 3M, Ortho Organizers, Henry Schein, MyoBrace, and obviously there I have consulted or evaluated products in the past, so there's the full disclosure for you. The disclaimer: I have been compensated in the past for consulting and or evaluating products for the sponsor, including Propel Orthodontics. For my participation in this event, I have received an honorarium from Propel Orthodontics. The opinions expressed in this presentation are my views and may not necessarily reflect the views or policies of the sponsor. The materials provided are for educational use and not to be used for advertising or product endorsement purposes. This presentation has been approved for continuing education credits. No photographs, video, or audio recordings are permitted during the presentation. So now, this is the third webinar in a series. We did 2 parts already, I believe 2 in 2016, and this is the third, so it's a little bit of a review of some of it. But the idea behind manual osteoperforation is that you're causing an injury to the bone, which causes inflammation, of course, and as the cytokine production goes up, your bone density goes down, you get the rate of bone remodeling increasing. So the idea is, as orthodontics is a controlled inflammatory response, if you can increase or boost the inflammatory response of the bone and surrounding structures, you get an increase in the rate of bone remodeling. So the basis behind all of this is to increase the rate of bone remodeling, which leads to an increase in the rate of tooth movement. So we get a increase in speed, basically, when we're injuring or wounding the bone. So when we're looking at manual osteoperforation, the basic 3 are going to be to evaluate, the sites. You're going to palpate. You can also use x-rays, mostly radiographs, and knowing your anatomy, where can we place the perforations. Of course, our goal is to avoid the structures like nerve and vessel and sinus areas that we might encounter in these regions. The little yellow dots on the screen will give you an idea that if we're looking to get into the bone, we would like to stay obviously away from roots, away from PDL, away from any vascular and or nerve bundles. And so that leaves us room interproximally, and whether we can do 3 in a triangle if the roots are far apart or 3 in a row, that's all an opportunity to perforate and enhance our orthodontic treatments. Chlorhexidine rinse is used. We do 2 times for 1 minute each prior to our perforation technique, so that's a standard. And then obviously we're going to use a little topical anesthetic. So we start with topical anesthetic because for a lot of areas that's sufficient. A nice topical anesthetic can be used alone since the bone is not innervated. Then again, you have patients who are a little more sensitive and may require a drop of a non-epinephrine. So I choose carbocaine. I like to use a non-epinephrine to go right on top of the topical, and I'm not blocking. The goal is not to block everything. I'd like the teeth to be responsive. So if I'm going to be perforating, let's say right over here, and I put topical gel, it's sufficient, great. If it's not sufficient, I'll go right over here and I'll put a drop or 2 of the carbocaine right in the same area. I'm not looking to go up in the vestibule and numb the entire quadrant, because then that defeats the purpose of having the teeth responsive. We want the teeth responsive so they'll actually let you know if you're getting close to them. So the topical anesthetic followed by a little drop of carbocaine is all you need. You only want anesthetic for about 5 minutes. That's really about all you need. So in general, what we're doing is most of the cases are a 1 to 2 treatment type of process. Only a complex case would require 3 micro-osteoperforation rounds. And so the idea is that mild to moderate cases around at the beginning, so a first round to start the case, and then about 10 to 12 weeks later would be the second round. A third treatment would be used in complex cases another 10 to 12 weeks later. And then what you're looking to do is as many perforations as are allowable by the analysis of the radiographs, okay? Now you do get a response away from the site. If we perforate in between 2 teeth, we're going to see a 6 to 10 millimeter range where osteoclasts are responding to that inflammation and the wound that we delivered. So now we can use it in 2 different formats. We can basically perforate around rate limiting movements, or my preference is to do the entire arch. So most of the cases that I've treated I just try to work first molar to first molar and deliver a dozen or more perforations in each arch. And so we'll talk about those as we show you some of the cases, but my preference is to deliver it for the entire arch. I work first molar to first molar. I'm looking to accomplish 12 to maybe 18 perforations in each arch, and then you have some really nice inflammatory response to that type of treatment, and you can cut your orthodontic technique in half with that type of approach. As far as the depth is concerned, certainly towards the anterior 2 to 3 millimeters is sufficient, but as you go to the posterior, especially towards the lower areas, you might want to get more towards a 4 or a 5. You have access on the palatal. The access on the palatal, again, you can go a little higher, like 4 or 5 millimeters, but in the segments not too far posterior where you might have sinus issues and or the vascular nerve bundles at the second molars. So the idea is my perforations are mostly 2 to 4 millimeters. The predominance of the perforations are between 2 and 4 millimeters, and rarely do I go to 5. And I find that if I'm doing 12 to 18 in each arch, I don't really have to go to 5 millimeters of depth, but the more comfortable you are with doing that, it's totally fine. Now, you get your peak effect at 24 hours, but it's going to remain for 10 to 12 weeks, and that's why we do the 10 to 12 week follow-up. So again, very mild case, 1 treatment. The mild to moderate, 2 treatments. Complex cases, 3 treatments. Again, the spacing is 10 to 12 weeks apart. Where we're perforating, it's wherever there's access. So the idea is to think about your radiographs and where you would find room. And if you want to think about it this way, anywhere you could place a TAD. If you've worked with the anchorage devices, the mini implants, the TADs, what you could do is think about where could I put a TAD? And then that's where you could perforate. So if you have radiographs that show you, well, I could put a TAD anywhere in these regions, you could perforate there. And it's the same exact diameter. So the TADs have a 1.6 millimeter diameter, and so does our bone cutting instrument. So our device has a 1.6 millimeter diameter. As far as the depth goes, this is a very nice chart from Dr. Baumgartel for TAD placement. So if you're familiar with any of his teachings, you probably have seen this chart before, but it gives you a good idea of where these depths can be reached, and your access to them is based on your radiographs. We would not be looking to perforate where 2 teeth are overlapping. We would be looking for the access, and that would eliminate some sites in crowding cases, of course. But if you could spread out 12 to 15 perforations in an arch, you don't need to necessarily get proximally into every single site. So the technique is really what's available. Do I have, let's say, 2 divergent teeth where if the roots are divergent and you want to make a triangle like this, you certainly can do this. If the roots are kind of parallel and they're not really divergent, you want to do 3 in a row, great. I'll take anything from 1 to 2 to 3. We have opportunities to do 1 sometimes, we have 2, we have 3. I don't know that a Panorex is enough, so in taking a Panorex, you might be able to identify some sites, but the Pan tends to leave some overlap and some ambiguity, so I'm not a fan of relying only on the Panorex. And I tend not to rely only on visualization or clinical evaluation. I will take individual PAs of the teeth and the roots in areas where I'm unsure to have a clear view about, okay, where's the access going to be for a case. It would look like this. The device is meant to be used almost like turning a screwdriver to rotate clockwise in and counterclockwise out. And as you're doing so, you would have a depth gauge to set. And this is what it looks like immediately after the perforation. So I consider it non-invasive because you're going to put a little topical gel, maybe a drop of a carbocaine. The anesthetic's going to last 5 minutes. You're going to make all your perforations. Once you're done, the bleeding is almost an instant stop, so we don't have that issue. And then the patient's going to take a couple of Tylenol, and we find that the comfort level is pretty high. This is not something that produces any significant discomfort. In fact, the patients take a couple of Tylenol on the day of the procedure, but I haven't had a patient need to take a Tylenol the day after. So we do administer a couple of Tylenol while they're in the office, and they're welcome to take it that evening before bedtime, which we recommend doing. It's just nice to have a good night's sleep. But the next day we follow up with a phone call and we make sure they're feeling pretty good, and I haven't had one of the patients need a Tylenol the following day, so it tends to be pretty comfortable, so to speak. So again, the technique is you're going to set the depth on your device. You're going to, obviously you're rotating clockwise in, it's like twisting a screw in and then twisting out, and then when you reach your depth, you're all set. Now the difference in technique is that we now have different opportunities, which we'll show you in a minute. There are 3 different styles of devices, which is going to be next. But post-treatment, we want to make sure we're sticking with the Tylenol product. An analgesic is fine. We're trying to avoid the anti-inflammatories. So it should be quite obvious. Avoiding anti-inflammatories is very nice because we're doing all these steps to make an inflammatory response greater than it usually is just from the orthodontic technique. And the last thing you want to do is be taking doses of anti-inflammatories and clearing the cells that we're looking to produce. So nothing wrong with taking some Tylenol. We give out 2 during the visit, and then we give them a couple to take that night for bedtime. And again, the next day, it really hasn't been a need for it the next day. As far as the choices of the driver is concerned, there is a single-use disposable that you'll see on the left side of the screen that can be used and deliver all of the perforations for a patient's visit and then discard it. And if you're doing 2 rounds on the patient, one at the beginning and one 12 weeks later, you would need 2 of those devices. The reusable handle in the center has a handle that is sterilizable, so this can be then sterilized, and then you're just replacing the tips. And again, 1 tip will do a session. So if you're starting the case and you want to deliver, let's say, 12 perforations in the maxilla and 12 perforations in the mandible, you would use this tip to deliver all 24 perforations, and then it gets disposed. When the patient returns 12 weeks later to do it again, a new tip would be inserted and used. So each session gets a new tip. Newer is an opportunity to use a power driver. Of course, it's chargeable, battery operated, and has all the settings so that you can, obviously there'll be a forward and a reverse because you have to forward in and reverse out, and then you're going to have a setting for RPM, and now you have all of the functions and features that make it kind of simple, and you press the button to turn it on, and next thing you know, it'll drive your way in and then drive your way out. Okay, so there's that opportunity. If you decide you need to have that, certainly the representatives would be happy to show you a demonstration of that appliance. Now, the benefits. Well, we're doing a fair amount of orthodontics in our practices, so the idea is if you have a nice orthodontic technique, that's wonderful. The idea here is the most popular question after how much does it cost me is how long does it take? So whenever we're talking about orthodontics, the top 2 questions are going to be, well, what does it cost and how long will it take? And that's where we have the opportunity to have a conversation with the patients. So typically we either talk or educate about our orthodontic opportunities that the patient would benefit from, and that leads us directly into the opportunity to have an acceleration of the treatment. The idea behind the manual osteoperforation technique is that it should take about half of the treatment time away, and so you're looking to have this opportunity deliver about 50% reduction in treatment time across any type of orthodontics that you might be providing. So there are wonderful advantages to doing that, and then the benefits extend past the patient and also into the practice. Now, as far as some cases are concerned, in the first 2 seminars that we conducted, the first 2 webinars, we reviewed a couple of cases, and so we'll go through those, then we'll present a couple of new ones to finish up the evening. So Dina presented to the office as a candidate for Invisalign, and she was happy to have that, and of course, we did our consultation to discuss what it would mean to have Invisalign, and of course, when the time frame came up, we started to discuss an opportunity to have a shorter treatment time. Early in the clinical trials, we had the opportunity to learn more about what type of speed we could offer. Dina was one of the earlier cases, and so what you're looking at here is just the beginning of the case where perforations were performed, and probably performed about a dozen in each arch, and we did 2 rounds for her. This case was slated to be 24 aligners, and with 24 aligners we would spend 12 months to treat that case. And in her case, early on in the clinical trials, we used a time frame for her that would be 9 months. So basically we took away about a quarter of treatment. In her case, she was changing the aligners every 10 days to remove about that. So 10 to 11 day changes to get her through about a 9-month treatment. Now the opportunity for her was to convert what she came in with, her mild malocclusion, so to speak, and have a finish that delivered a healthy, stable, and functional and comfortable occlusion. And in the end, by the time we got to the final result, we had corrected the crossbite on the right side. Her canine was in crossbite, and yes, you're looking at a primary tooth here. I should make mention of that. She was congenitally missing tooth number 20, and so in the end, we did the orthodontics in preparation for the implant placement here. So we're going to see in the occlusal views where that would be replaced with an implant at some point in the future. So the correction of the crossbite and the correction of the malocclusion is accomplished with a 24 aligner count. And this case was treated with expansion. The widening of the arch and the developing of the arch form of the upper allows us over 24 aligners to produce a nice arch form and a nice arch width. And then the end result on the lower is that it can follow it. So if the upper is expanding and the lower is expanding, we did use a little bit of lower IPR for this case. So I had a couple of millimeters of IPR, and I did focus it around that the primary tooth. So I took about 1.5 millimeters away from the primary tooth just to reduce its mesial distal width a little bit in preparation for a future implant. This case was treated, I think, about 5 years ago, and of course that primary tooth is still there. So now that I have this all prepared and ready for the implant, watch what happens to me. That tooth will probably last her another 50 years. So the idea is a nice wide arch form, a beautiful shape to it, everybody where they belong. So we end up delivering a class 1, a healthy, a stable, a functional, a comfortable occlusion, whereby the patient now has a proper arch form and a proper arch width. The patient has appropriate buccolingual inclination. The patient has an acceptable overbite, overjet. They do have a canine guided or protected occlusion, and she does have posterior intercuspation without interference. So of course, as the months go by, we would check the occlusion to make sure that we deliver a healthy, stable occlusion for her. The difference in her case was her 24 aligners was used fully, did not need a refinement, so I did not have to get additional aligners. And the 24 aligners being worn at a 10 or 11 day interval ended up being treatment time of about 9 months. So early in the process, we had secured about a 1/4 to 30% reduction in treatment time, and then we worked our way to about half. So I'm going to show you the cases as we get to the halfway mark, where 50% of the treatment time goes away when we're wearing the aligners at a 7-day change for some of these cases. So we get a nice result, we get a nice occlusion, we get a happy patient. She'll wear her retainers at night, and she did have 2 rounds of micro-osteoperforation, 1 at the beginning and then 1 about 10 to 12 weeks later. And then that was it for the case, 24 aligners, 9 months. We also showed another case. Veronica came in, and she has tooth number 10 kind of trapped back there. She has very nice teeth individually. They're perfect, but she just needs a little help getting that, sneaking that number 10 into the arch. So young adult, doesn't have the interest in wearing the braces, was interested in Invisalign. So we went ahead and talked to her about Invisalign, and then she had an interest in quicker treatment time, so we kind of pursued that right away once we talked to her about the options for micro-osteoperforation and what it could do for her. Similar in the technique, we're looking for expansion, we're looking for arch development. So this is an Invisalign aligner case where we walked her from this before to this after, and we show the arch form, the arch development, the arch width. We get a nice arch form, nice arch width. Of course, we'd like to coordinate it with the lower, so we get ahead and have all of those teeth unravels. Not very severe a case, kind of on the mild side, but it does help us get that tooth in position. So we end up with an occlusion that has a proper overbite and overjet, a canine guided or protected occlusion. She's got posterior intercuspation without interference, and in the end we end up using 40 total aligners to complete that case, but it took a treatment time of 12 months. So as the cases went by over time, we started to learn a little more about the reduction of treatment time. Now 40 aligners would normally take 20 months. If I was doing the 40 aligners by the typical pattern of a 2-week wear time to correct a malocclusion like this, where we've got an anterior crossbite, we got a posterior crossbite on this side, we would take that patient through 20 months. And 20 months isn't bad. It's still clear aligners. You still get to throw bleach gel in there. You're still happy at the end. You got a patient who's getting their teeth in place and having a nice smile. But the opportunity to go from 20 months to 12 months is very nice. It's not exactly cutting the time in half, but at this point what happens is we were starting to reduce the rate of wear. So to go from 20 months to 12 months isn't a reduction of half. This is probably someone wearing the aligners at maybe a 9-day interval to get this amount done, but we're going to get to our 7-day wear time coming up shortly. As we moved on to Andrew, what happened here is Andrew came in and he has the opposite lateral kind of trapped behind there. Tooth number 7 for him was trapped behind there. And as we got to Andrew, he presents again with a malocclusion that we'd like to unravel, and of course again it's another clear aligner case, so he happens, for disclosure purposes, it happens to be treated with Invisalign. I'm not here to promote Invisalign, but that was what was used. So if I say clear aligners, it's Invisalign, it's the only one I use. But here you have Invisalign taking him from a starting point of a kind of a terrible malocclusion with lots of crowding and terrible arch form like an omega to a fully developed, beautiful arch. So he's got the omega shape. He's got number 7 trapped back here. Again, we're going to look for the same thing, an amount of expansion to develop a proper arch form and a proper arch width. We're going to look to bring that tooth number 7 into the arch. This is a case that's treated without any IPR, and so we deliver the aligners one after the next, and he ends up wearing I think 33 aligners to treat the case, but I think we'll have that number towards the end. The lower arch is fairly collapsed. He does have every bit of the malocclusion showing up. The buccal cusps are getting kind of worn because of their position. They're elevated as the tooth tips in. The buccal cusps tend to take the beating. So we have a fair amount of crowding, a fair amount of collapse. We'd like to open that all up and develop a nice arch form and a nice arch width. His case took 3 rounds of Propel. So we did a beginning and then a 10-week and then a 12-week later. So we ended up 3 rounds to get that malocclusion resolved. And of course, at the end, we're trying to have some nice credentials. So we'd like to see a proper arch form and a proper arch width and follow it with a nice overbite and overjet. Canine protected is nice. And if you can get posterior intercuspation without interference, those are good credentials as well. And then we expect to have, nice stability. And this case ends up taking 10.5 months of treatment time, and his aligner count was about 36 aligners, I think 33 to 36 aligners for 10.5 months treatment time. Then we move on to our next case, Chavez. We meet Chavez, a young guy here. We got an 18-year-old, so he comes into the office again. Senior year of high school is a tough time to be wearing braces, especially you'd probably be the only one, so he's not a big fan of having braces put on. But again, we'll meet, we'll talk about Invisalign, and if we're talking about Invisalign, we may as well offer a full correction of his malocclusion. And so we're going to look to take his omega shape and develop some nice width. Of course, number 14's got a little decay, so he gets a composite in there before treatment, so a little composite to take care of the decay. But at any rate, again, another case treated without IPR. The opportunity to expand and open up the arch and develop a beautiful arch width and have all those teeth line up nicely is very possible. So we're going to use the clear aligners. We're also going to use the micro-osteoperforation for him. He's going to have 3 rounds to treat this case, an initial round, and then a 10-week to 12-week later, and a 10-week to 12-week later. Each round will be at least a dozen perforations in the arch. So by the 3rd round, sometimes I get down to about somewhere between 4 and 8, because by then the movements are minimal. You have a lot of mobility. You built a lot of inflammation into the arch. So I tend to wean it off, and I have a little chart to show you there later on. So the case comes in a little collapsed. We got, number 29 is sitting here poking at his tongue and everything, and I'd like to save that tooth. So I'm a big fan of widening and opening things up. So while you have an 18-year-old, you got a lot of opportunity to do this. This case is treated again with an Invisalign technique without any IPR. All of the teeth are there. You can recognize we got all the teeth in place. So no IPR, but definitely the micro-osteoperforation, 3 rounds, and a beginning round, and then a middle round at about 10 to 12 weeks, and then a 10 to 12 week later 3rd round to get that case treated. And so now we've got our arch width, we've got our arch form. We're going to end up with a nice overbite, overjet, a canine protected occlusion. The posterior is fully interlocked. He's got the posterior intercuspation without interference. Without any IPR, it's a reasonable result. The midline being half a tooth off at the beginning makes it challenging to kind of get that without some IPR. So, you can always go at that case from one of 2 directions. I tend to prefer not using the IPR. And if this is an issue for a patient, we would talk it over, and we could certainly do an IPR that's staggered to help maybe get the midline a little bit better, but I didn't use any IPR for the case. We just kind of moved the teeth where they belong. So now, as far as comprehensive care goes, certainly we're helping him solve his malocclusion, but in solving the malocclusion, if we're addressing the arch width and the arch form and, giving, if you look at the previous photograph, everybody lined up nicely and fitting in, it develops a pretty good smile. So he's got a nice full smile. He looks terrific. And so here we have another result that took about 10.5 months of treatment. 6 months later, we get a retainer check. So at the end of treatment, he gets an Invisalign retainer. He wears it to bed every night. He comes in 6 months later, and he's got a little hairstyle going. He's got a little facial hair. He's now going, into 18, heading towards 19. Since when we started him, he was like 17 years, 10 months, I think. We started him just prior to his 18th birthday. And then what happened was we were taking a lot more pictures, but you could see what developed here. His case was treated without any elastics. So we had Invisalign alone to widen, to upright, to broaden, to expand, whatever you want to call it. But all of that arch development led to a correction in a lot of things, including the profile. And so what you recognize in this picture is someone who's kind of overclosed with a deeper bite and the lips kind of everting here. And you get a right angle over here, and then when you upright everything and widen that all and produce a beautiful occlusion form, all of a sudden his facial profile changes and you get a perfect lip display and all kinds of smooth contours here instead of this right angle. So the opportunity to make this type of facial development occur by expanding and moving all those teeth into place with the Invisalign combined with the micro-osteoperforation technique ended up taking about a 10.5 month treatment time to do this case without any IPR. Is a nice opportunity, and 10.5 months of treatment for that is great. Without the micro-osteoperforation, easily that's 20 months. I would have spent 20, maybe 21 months playing with Invisalign and gotten the same result, but to have the treatment time be shorter is fantastic. Now those cases that I just presented were review. If the previous webinars are archived, and I believe they're archived on the website propelortho.com, you can see them in a little more thorough and entirety. Those were a review from the previous 2 webinars. This one's a new one though. This is one of the new cases we're showing tonight, where the patient walks in with a bit of a malocclusion, and certainly they're having a little bit of an issue with the teeth, and of course the gum tissue is not perfect. But the idea here is we've got arch collapse, we got a malocclusion on the upper arch. We got some spacing. There's a little spacing over here, but we have the omega as well. And the tooth number 1 is there. That's a wisdom tooth. We have the arch form is more like an omega, and so we have an opportunity to kind of open that up. We have the lower teeth, but they're kind of collapsed, so they're leaning in a little bit. And this doesn't lend itself to a very nice occlusion. It's full of interferences and quite a bit of horizontal force on the back teeth. And if we're going to use Invisalign in a comprehensive mode, we'd like to talk about clear aligners to treat the case, but then also offer the treatment time to be reduced. And so this is a patient who accepted a treatment plan of restoring the spaces for the first premolars in the upper arch, and with the micro-osteoperforation technique combined with the Invisalign aligners, we were able to open up those 2 spaces to deliver the 2 implants. And then because the lower premolars were there, it gave us a better opportunity to match up the occlusion for him. So we went ahead and, in this particular case, delivered the palatal perforations, because we have opportunity to get some palatal here, and if we can do buccal and lingual, we get a lot of response in this area, and then we're going to have pretty good control over these teeth. So this is what the first aligner looks like. And then over time, we get to 26. And by the time we got to aligner 26, now we have opened up those spaces for our premolar replacements. And then we could take a look at a before and after, and this is what it looks like after 26 aligners. And so here we have him doing, with this type of treatment, we usually do maybe like a 9 or 10 day change just to make sure that we're tracking nicely. I wouldn't necessarily use a 7-day change with the micro-osteoperforation. This is asking a lot of the Invisalign. And again, this is without an expander, no braces or wires, just Invisalign straight through. We can take this to this, and for these types of cases, 9 to 10 day changes with the micro-osteoperforation are great. If you're not using the micro-osteoperforation, a full 2 weeks of wear time will help you out. But what we want to do is make sure we develop a full site for those 2 implants. We have a full width developed. We're going to have a beautiful arch form, an arch width that'll accommodate 2 fixtures. Now, I don't place my own implants, so I would refer him to a periodontist, and it turns out the periodontist in the town is Dr. Evan Cantor, so I want to make sure we give appropriate credit. The implants were placed by Dr. Evan Cantor in Mount Kisco, New York, and here they are. So you could see, well, we had our room, we put the 2 fixtures in there, right? This happened to be my partner's patient. So my partner is Dr. Gene Getz. So of course he made the implant crowns for him. So I did not do the restorative. The implant crowns courtesy of Dr. Gene Getz in Mount Kisco, New York. That's my partner. So he delivers the implant crowns. Now what we have here is a full development of the arch width and the arch form, and a 7mm site to get our implants in there, and a full-size implant, not a mini. And then by the time we're done, we have a beautiful occlusion. So we unravel the lower crowding, and next thing you know, we have a nice overbite, a nice overjet, a canine-guided occlusion, posterior intercuspation without interference, and having that broad, wide arch development, and then the 2 implants restored delivers a nice occlusion. And you can see that the gum tissue is responding very well. It's improving around the teeth. The lower teeth, we get them upright. So the opportunity to upright the posterior segment by opening up and expanding the upper gives us teeth that can now have basically vertical force on them instead of leaning in and having a horizontal component. So we're trying to get that posterior intercuspation without interference to develop that broad, wide, upright arch, and in the end it improves the smile as well. And having the premolars extracted and maybe a little narrowness in the upper arch, if we can get back to where we were, all of a sudden, those two teeth kind of blend in very nicely. And next thing you know, you have 2 implants in your first premolar site, and you got a full, broad, wide smile, and you have a patient who's very happy. And a little bleach gel goes a long way, so of course you can take some stain off while you're wearing your clear aligners. You get a little bleach gel in there, and that does a wonderful job for you. Now, as far as the micro-osteoperforation, this chart, I'll keep it up here for a minute or two just to get a look at it if you want to jot some notes down here. But what I divided it into was I tried to make it as generic as possible, but nothing is really carved in stone. But these are general guidelines that kind of fit for me. And so I call this round 1, micro-osteoperforation 1, and then micro-osteoperforation round 2 would be about 10 to 12 weeks later. And micro-osteoperforation round 3 would be 10 to 12 weeks later. I tried to divide the cases into mild, moderate, and severe, and dividing those could be different for different people, but I tried to give you something that if it's around 9 months of treatment time or less, you're probably in the mild category. Something that would take 10 to 15 months for treatment is moderate, and if you had to go 16 or more, you probably have some more severe malocclusion on your hands. So these are general guidelines, but what I'd like to show is if I have a mild case that's going to take 9 months or less, 1 application is sufficient. We can work with about 8 to 10 micro-osteoperforations per arch. So that means we're going to make, let's say, 10 perforations in the upper arch and 10 perforations in the lower arch. And at that level, with a mild case, you could change the aligners every 5 days. I didn't show a mild case today, but if I had something small, you could cut the aligner wear down to 5 days now. You wouldn't need a second and third round. Okay, if you get into a moderate case that's so-called 10 to 15 months of treatment time, I would increase my perforations per arch. I'd like to cause a higher degree of inflammation. So I would go up to a 10 to 12 MOPs per arch. So that would mean, okay, somewhere between 20 and 24 per mouth, because you're going to do 10 to 12 in the upper and 10 to 12 in the lower. A moderate case, I'm going to easily think about doing a 7-day aligner change, but I will do a second round. Okay, and the second round would be 10 to 12 weeks later. I'll deliver maybe half of that amount. If I gave 4 to 6 in each arch, it would be enough to support that inflammatory process riding the case throughout. Now, when something gets severe, if the malocclusion is really tangled up in something severe, I would like to get a lot more perforations. I'm looking for 12 to 18. And if I could perforate 12 to 18 in each arch, I have an opportunity to do a lot of inflammatory process in that alveolus and give those teeth an opportunity to have that bone remodeling faster. But I would say on the conservative side, 9-day aligner changes is very nice. A lot of these severe cases can go to 7-day change as long as you're delivering the MOPs. So you have to do the perforations to generate the inflammation to be able to go to a 7-day change. I threw 9 on here to be conservative. So this is a starting point. If you want to get to a 5, a 7, and a 9-day change in your mild to moderate to severe, these are the number of MOPs that I've seen work beautifully, and the tracking's great. The cases that you've seen today didn't really have any additional aligners or refinement aligners built, so tracking's good too. What's the point in doing 7-day changes if you still need a bunch to finish the case afterwards? You haven't really saved yourself a lot of time. So the more cases you do, the more you feel for whether or not you can get an 8-day or a 7-day change out of your patient, and some of it has to do with the wear time. If they're going to wear them well, great, that's easy. If they're not wearing them well, then maybe you got to think about going the extra days. But in the moderate category, two rounds are appropriate. You want to get the first round in at the beginning and then get your 10 or 12 week mark in and deliver again a second round. But when you get to severe, I like to do 3 rounds. So a severe case, if you're going to be in that, let's say, about 1.5 years or over type of category, you might want to think about getting 12 to 18 per arch. Those perforations, again, 12 to 18 perforations per arch. Work on a 9-day change till you're comfortable with the system. These are cases that are probably going to be 7 days as you get more comfortable with delivering these perforations. Of course, the second round should still be pretty heavy. In a severe case, 12 weeks later, you're only 3 months into that case. So you want to deliver a significant round of inflammation. Again, you go 10 to 12 again. It's the third round that can drop, okay? The last round can drop off, so maybe 6 to 10 in each arch. And then as you have more experience delivering 9-day changes, you can start to go from 9 to 8 to 7 and work your way down. Some of the cases we'd start off with 9, we'd see the tracking, and then after doing 5 or 6 aligners, if you feel like it's really looking great, go to 8 days. Do a few aligners at 8 days, then do a few at 7. If you feel like you're slipping a little, go back to 8 or 9. You know, this is totally flexible. The idea is to kind of manage how many perforations did I have access for, Because if you're looking at a severe case and you just don't have access for this many, maybe you can only get 10, maybe you can get 8 to 10. If I have a severe case that's so tangled up and I just don't have access to get 12 to 18 perforations, I might get 8. If I get 8, I might not reduce the aligner wear time to 9 days. Maybe I stay at 10 or 11. So again, some of this has to be massaged dependent on the case in front of you. So this is a general kind of chart, guidelines to keep you in a conservative kind of mode for starting, and then from there you build it on your own comfort level. It brings us to the next step that's available, which is high frequency vibration. And so high frequency vibration has a helpful role with as far as clear aligners go, and the idea here is these cases benefit from having the aligner seated perfectly. And so what I'm using this device for is to help make sure that my clear aligners are seated completely. And the goal here is to use this device, which is called the vPro 5, for 5 minutes every day. Okay, it's got a power button. It's rechargeable, so you charge it up. When you press the power button, this vibrates kind of like your cell phone does. But the idea is when you place this right in between the teeth while you're wearing your aligners, it's going to guarantee that those aligners get seated fully, and it does make sure there's really nice tracking. So the idea here is you've got a mouthpiece, the oscillator is here, and it'll come with a USB flash drive, so it has some usage software in there, but you get a wall adapter to plug into your USB and charge this thing. Now, there's a status light right on it. Okay, so when the light is blue, it means you've turned it on and it's going to run 5 minutes. It does a 5-minute cycle and turns off after 5 minutes. When it does that, the green light's going to blink 3 times, and now you've completed your 5 minutes. And then obviously when you charge it, it'll be green. When you're fully charged, it'll stay green, so you're on. Now, if you get red for 3 blinks, well, the switch was pressed before the treatment was complete. If you turn it on and it's blue, if you turn it off in the middle of treatment, it's going to blink 3 times. It'll let you know you didn't do the full 5 minutes, okay? So if you interrupt the treatment 5-minute window, you'll get that little blink. So now magenta is the color it turns when the battery level's low, and then amber is what it turns when you've got it plugged in and it's charging. It takes about an hour and a half to fully charge it. On a full charge, it'll deliver 5 minutes, anywhere from 5 to 7 days before you charge it again. So once a week you put it on the charger, you charge it up. So it's a simple device to use, and it does have software that can be used for kind of compliance to see. So you basically log in and you assign the device to your patient, and then you can then access their usage data. So when they're using it, it's going to show a log of, okay, the 5 minutes was done every single day. So you get to see it, how that's going. That's a nice way to check the compliance. 5 minutes a day is pretty easy, so that you don't find many people having trouble or struggling with their 5 minutes. So now, as far as a clinical case, I'll show you someone here where we did change the aligners every 9 days, and so we have a patient with a desire for the clear aligners, so we're going to offer Invisalign. And then we've got a malocclusion on our hands. It's not a healthy place to leave these teeth. We have someone young who's already showing some recession. We've got a rotated premolar. We've got a bit of a crossbite over here. So we have issues. But anyway, this malocclusion has some crowding, and we'd like to recover these teeth. The patients had their share of dentistry. We're even missing a premolar at a young age. So we have the rotation of the premolar right here. It's turned, whatever you'd want to call that. I don't know if it's 80 or 70 degrees, but at any rate, this is the buccal face right here. The buccal face is directly facing, anteriorly. We'd like to get that back in line and secure a better occlusion here for our patient. So we have every bit of a malocclusion and already some signs of wear and tear and deterioration. And the patient having a full mouth of amalgam in the back doesn't help either, because now we've got a patient that has a malocclusion and has a lot of old and large fillings in the back. So this type of malocclusion is bound to deliver cuspal fracture. So we're going to look at this and recognize in the future, it's a restorative dentist dream. You're going to end up with a bunch of crowns in this mouth. The teeth are just going to fatigue in the back under all that terrible stress from the malocclusion. So if we deliver a device and ask her to use it for 5 minutes a day, it's going to help seat those aligners. We're going to keep them locked in nicely because she does not have a deep bite. So a case like this, to unravel it, we'd probably expect to see anterior attachments on. So we're going to put every one of these attachments on here, and then we're going to have her use that the vibration device so that we could make sure her aligners seat beautifully. And this is aligner number 10, so just showing a tracking, beautiful fit of the aligners at number 10. This would be an important attachment here to make sure we stay secure as we rotate that tooth. And by the time we get to 22, we could still see by aligner 22 that we've got a very nice fit. You know, this is an aligner that is seated well, tracking well, and we'd be interested in moving right along. By 34 aligners, the bleach gel is taking effect, so we're lightening the teeth. Patients are always happy about the bleach gel. This tooth is rotating, and we can see where the stain is on the surface that was rotated against the canine. So all these years that tooth, that face has been turned in there. So when this, you know, gets rotated out to place, we're going to notice that stain and even a little bit of an enamel issue there. We might have to do a little filling at the end. But at any rate, the tracking is very nice. All of the teeth are fitting in here at aligner number 34, and you know, if we're changing them at 9-day intervals, we're having a little savings of time with good tracking. So by the time we get here we are with number 34 in place. We've got a nice arch form, a nice arch width. The tracking's very nice. We're coming along. This is a case that requires some refinement aligners, but that tooth number 21 has achieved almost a full rotation to place, whereas now it's lined up, and before it was turned, you know, pretty nicely. So we've got some good tracking. We've got a happy patient. When we get to aligner 34, it's time for some refinement, and so the teeth are heading in the right direction, but not finished. So if we look at a case like this, and we've got her at this point with 34 aligners under our belt, 9 days, we're saving about a third of the time. But at any rate, what we're really looking at is how nicely the aligners were seated by that vPro 5 or vibration device, and that allows us to have an opportunity to keep our tracking on course. And if our aligners are seated nicely, we're going to go from one to the next and move on and end up having an arch form that's developed, an arch width that's developed. We get our canine back in the arch, and then we get to a point where we're ready for some refinement or additional aligners. And so this is a fun area to see the tracking over here and how nicely this went. These two teeth are folded onto each other almost buckle to buckle. And then by the time we get through 34 aligners, that's some nice tracking here without any elastics, just going aligner to aligner. And then some photographs will be taken here with the purpose of doing refinement. So while our occlusion is coming along, we're getting out of that crossbite, we're getting a better adaptation to get our canine guidance back. We'll probably have to do a little restorative procedure here where they were leaning on each other all those years, but that's okay too. The point is, it's not completed here at 34, at the stage 34, but we were able to have, you know, some very nicely fitting aligners throughout the process using the vibration device. Now, at that point, we're only in about 10 months. So the 34 aligners takes us a 10-month time frame to get to here. And that's a good stage to be at. If we started here and got to here in 10 months, taking impressions and photos for some additional aligners to wrap up the case would be wonderful. And that gives us the opportunity to get a few more aligners to wrap that up. Now, in, again, the beginning cases, if you're tuning in as your first time listening to these types of webinars, there were 2 webinars preceding this, one in October and one in June of 2016, where the beginning cases were shown in more thorough detail. This was more of a review and to just introduce the vPro 5, the device to kind of help seat aligners. So if you would like additional information on some of the techniques involved with treating the previous cases, the previous webinars are available. So there's 2 ways to get more information. You know, one way is to be able to go to the website, and that would be www.propelortho.com, and the other way is to call a territory representative. And so Propel does have territory representatives, and basically what happens there is you can invite them into your office. They're happy to come in and do some demonstrations for you, show you each of the devices and all of the features, and you know, having a little hands-on demonstration is wonderful. So I think the idea is, if you're interested, the website and or a territory representative is a way to learn more. And I'm opening up the question box just to see if anybody has any questions, because I'm saving these last 10 to 15 minutes for a little Q&A. Obviously, you can type in questions that you have, and I'll go through a few of them now to wrap up the evening. And thank you for your kind attention. So let me see some of these questions here. I've heard about some providers delaying Propel until week 2. Do you ever recommend not propelling at day 1? Well, it's an interesting concept. I don't think there's any matter in which that would be a negative. I don't mind when you do it. The sooner you do it, the better. If you want to wear an aligner or braces for the first week or two, the idea is at the beginning, I like to get started with as much inflammation as possible. So I tend to do it at the first stage. The day the patient would have their braces put on, I would do my first round, or the day that I was going to deliver the first aligner, I would do the Propel. Let's just get the inflammation going and start moving the teeth. But second week doesn't bother me at all. I don't think that's a problem. If there's any preference, I think what you're doing there, if you're having them back week 2, you're adding an appointment time. If one of the opportunities that you're thinking about incorporating this would be the profitability aspect, the profitability aspect would be affected by the additional appointment, because now you're adding time to come back. Whereas if you're in the one single visit to start your case, deliver your orthodontics, whether it's braces or Invisalign, and then do the Propel, maybe it's more efficient in the timing as opposed to a second visit. But I don't think it would matter to me. I can't think of a reason why this would be a good or bad idea. So if you want to do it in the first week or second week, no problem. All right, let's take a look here at another question. Let's see here. You do a lot of expansion cases. I'm wondering how often you recommend gingival grafting in cases with thin peri or inadequate zone of attached gingival buccally. So, yep, it depends. If the posterior areas like canine back have recession, clefting, or abfractions, typically those teeth are leaning in towards the tongue. And so I'm usually trying to address that horizontal force. So I find that when my patients come in with crowding, the back teeth are usually leaning in, and when the back teeth are usually leaning in, I see recession, clefting, or abfractions. So the idea behind the posterior expansion is it's an uprighting. The uprighting of the teeth delivers vertical force. So you're correcting the malocclusion from horizontal to vertical force on the back teeth. What it does is it eliminates all the interferences. Eliminating the interferences and changing the force direction on the back teeth from horizontal to vertical tends to heal or improve the gum tissue. So abfractions stop and they don't get deeper once you have the correct occlusion. Anything that's clefting tends to repair itself, and then gingival tissue tends to cover more of the teeth. And so I've done a lot of webinars and coursework through Invisalign where we show the periodontal improvements. As far as the anterior teeth are concerned, if they're showing buccal gingival recession, those teeth are brought back a little bit. So we tend to retract them a little bit to get them centered in the alveolus. But as far as the 1,000 cases that I've treated, only 2 people have had a gingival graft. And I tend to do almost no IPR, and I do a lot of expansion and uprighting. So I basically treat with the philosophy of non-extraction and little to no IPR. And the cases you're seeing are representative of what I do. And I've only had 2 people end up with an individual graft, and I can tell you the teeth. One was number 8 and one was number 11. And I know the 2 patients off the top of my head. They're definitely in a webinar somewhere. But the idea is the quality of the gingival tissue is affected by the occlusion. And the more the back teeth are leaning in, the worse the gingival buccal areas are. Uprighting them tends to improve those cases. Let's see here. What are the standard charges for MOP sessions? Well, you can break this up a number of ways. As far as the standard charges, I tend to make one fee. If I know I'm going to deliver an orthodontic technique plus an acceleration of some sort, I usually like to give one fee. I assign the fee to the patient and then they pay for the case kind of thing. If you want to divide it out, I'm not as good at doing that. So I wouldn't know how to, let's say, break out the fees. But I think the website might have more information on, like, let's say, charges and financing type stuff. Whereas I'm more comfortable just giving the patient a single fee for the treatment, and it includes these things rather than dividing it out. Is there any indication that VPRO 5 increases inflammation, or is it success completely attributed to helping the aligner seat fully? As far as the VPRO 5, it's a little more new. So as far as that high frequency vibration goes, helpful in seating the aligners, and I don't have an answer as far as increasing inflammation or increasing speed, okay? As far as the patients on steroid therapy, that's a good question, because if you have a patient who's on a steroid therapy, you have anti-inflammatories on board, you might want to choose your orthodontic treatment time a little bit differently and see how that goes. If your patients are on high steroid doses, you might want to slow down treatment and not speed it up. But the idea is to proceed with caution for patients who are on steroid therapy. So you mentioned you do your perforations first molar to first molar. How do you typically space them out? In other words, if you're doing 12 to 18, where would you do them? It would be wherever there is access. And so the question about where I would space them, if I can get myself to the first molar, I know that response will be 6 to 10 millimeters away. So I don't have to necessarily get back between the first and second molar. If I can get the first molar perforation at the premolar, first molar, great. Sometimes you can do the second molar to first molar interproximal. But the idea there is, with all of those sites available, how many can I get? And there are sites that are sometimes blocked by roots that are converging. So the idea is not to get in between every single tooth. The idea is to make sure you achieve about 12 to 18. And sometimes we miss 1 or 2 interproximals. But even if we have 2 interproximal areas that are kind of blocked by root convergence, we would still have representative inflammatory markers 6 to 10 millimeters from the spaces next to it. So the idea is, if we can go ahead and get perforations spread out across the arch, chances are we're going to have a wonderful opportunity to accelerate the treatment for that case. I haven't come across a case yet in about I think it's 5 or 6 years now. I'm doing this since 2011 or 12. But the idea is, I haven't come across a case yet where there have been so few areas of access I was worried about it. It should be easy to get a dozen sites and up to 18 for severe cases. All right, so how many Invisalign trays do you normally give patients when implementing Propel? And so I typically follow the 3 aligner pattern. When I use Propel, I start giving out more because at this point we're doing 7-day changes for the severe cases. If you have a very mild case, you might have looked at Invisalign recently, looking at it and having a 7-day aligner change recommendation, and that can be done for the mild cases, and then by judgment, again, up to the doctor's discretion beyond that. So if I'm going to have them change them weekly and I want to see them in 6 weeks, they would get 6 aligners, not 3. So if you want to do a weekly aligner change, then you go ahead and you give 6 aligners if you'd like a 6-week interval. If you want to see them in 4 weeks, you give 4 out. It's simple math, but the idea is I like to give the patients about 6 weeks worth and come in on a 6 to 8 week interval, okay? And then we go ahead and follow that pattern, and based on the wear time, we just do the math and hand them out. All right. All right, let's see. Invisalign now recommends weekly aligner changes. Do you agree? With the addition of Propel, can this get sooner? So here's the issue there. When it comes to the weekly aligner changes, the key words with the recommendation is that it's at the doctor's discretion. So Invisalign knows from now having some pretty significant research to show the tracking is very nice at 7 days. There are a lot of Invisalign cases that can be treated with 7-day intervals, which would mean if you now can accelerate that, you're changing them less, which is why on that MOPs chart I drew up before, I had 5 days listed for mild cases. A mild to moderate case can be worn a week at a time, as it is now, but the idea is if you want to introduce the micro-osteoperforations, you now have the opportunity to reduce that time to less. And I believe there are cases being treated at 2 and 3 and 4 day aligner changes with a micro-osteoperforation technique. So that does exist. Yes, happy to offer that. Okay, now, do you feel like you can increase the velocity of treatment faster with the Propel or the high-frequency device? The Propel. The Propel is a wound to the bone. When you're perforating, you're getting, and you're going to increase the tooth movement. So you're going to get a greater level of the cytokine production. You're going to get a greater level of inflammation. You're going to get the bone to remodel faster. The Propel perforation technique has been shown to increase the rate of tooth movement, okay, by increasing the rate of bone remodeling. But as far as the high-frequency device is concerned, too new, and it really is meant for aligner seating. Now, aligner seating, if you have the aligner seating beautifully, what you're really guaranteeing is your tracking. And if you have your aligner seated beautifully with that 5-minute technique, now you're going to go ahead and have beautiful tracking to keep you going. So yeah, the question has come up a couple of times where, using the Propel and the vibration device, you can use both. There's nothing wrong with using the Propel and then delivering the vibration device. I've never used them together. I use one or the other kind of a thing. All right, if a patient doesn't show up for a follow-up appointment and you have propelled them, do you continue with the rate of changing or re-propel prior to delivering aligners? So certainly that's an issue because you would give out the number of aligners that'd be appropriate, and then they're due back to see you. Now, if they don't show up for a follow-up appointment, they're just stuck wearing their last aligner. So they can't keep changing aligners that you're holding. So if a patient doesn't come in, of course, we're going to call them and say, okay, we were due to see you today, and let's get back in touch so we can get our treatment on track. Then it would depend upon when they came in. If a patient disappeared for a couple of months, all of a sudden I'm keeping track of my 10 to 12 week window, because if I perforate that arch and I get, a beautiful inflammatory response that I know is going to last 10 to 12 weeks, if I pass out of that window, I may want to deliver a significant propel at that next time the patient comes in to restart that case. Whereas normally flowing through the case, I'd be reducing the number of propel perforations in each arch. The topical. One of the questions here is about the topical I recommend, and of course I can't remember the name, but it's a concoction, and I believe it's mentioned on the website. If you go to the Propel Ortho website, they have in there somewhere the mention of the concoction that is a mixture for the topical, which is beautiful, and of course I'm drawing a blank. So we handled a few questions. I really appreciate your time. I would refer you for 2 sources to gain more knowledge. 1 hour is kind of short, but at least I had a chance to kind of review a few cases that were presented in more detail in previous webinars that I believe are accessible to you on the website, and then to show you a little bit about the vibration device that's also available, the high frequency vibration. And then I would refer you to propelortho.com to learn more, and also I would refer you to their territory representatives. And on the website there is a locator, so you can always go to the representative locator to be able to find someone. And then let's give you one more question. One more just came in. Let's cover it. If a patient had wisdom teeth extracted and is having a natural cytokine response, do you also propel anteriorly? How many perforations? Oh, the wisdom teeth are beautiful. And so, yeah, if I have a case of let's say that age where we're doing wisdom teeth extractions, I like to start my ortho. So what we do there is the wisdom tooth extraction will be set up somewhere in the case so that I can take advantage of that wound, because that's a big wound and that delivers beautiful posterior movement. So I'd like to have the wisdom teeth extracted somewhere between aligner 1 and 15, like in the first half of the case, to take advantage of that 12-week release of the inflammatory markers to heal that wound. So I wouldn't propel around the time of the wisdom tooth extraction. That's totally enough. So what I might do is either do an initial propel at stage 1, then if we go 10 to 12 weeks later, go get your wisdom teeth out. That's 3 months into the case. Or that could be propel, and then the next round could be the wisdom teeth. So that has happened before. We've had the advantage there. That's very nice. So if you're going to have any consideration for taking out wisdom teeth, try to do it during treatment, in the first half of treatment. Take advantage of the opportunity for that response, and you have a wonderful opportunity to have that contribute to the tracking and movement of the cases. Well, we've reached 9 o'clock. We've answered a bunch of questions. We got to show you a little dose of what's going on and what's available to you. And I can tell you my experience has been fantastic. Again, it's just my opinion, but it's something out there to look into. It's not for everyone, but I would encourage you to at least look a little further than this 1 hour. I hope you enjoyed the session. I want to thank you for your kind attention, and good luck going forward with your future in accelerated orthodontics, thanks to Propel. And have a good night. Thank you.